Imagine a heart where the body's blueprints got a little mixed up. That's essentially what happens in transposition of the great arteries, or TGA. It's a serious congenital heart defect, meaning it's present at birth, and it affects how blood flows between the heart and the lungs, and the heart and the body. This video will explain all aspects of this complex condition. The exact cause of transposition of the great arteries is often unknown. We do know that it happens during fetal development, specifically within the first 8 weeks of pregnancy when the heart is forming. Genetic factors may play a role in some cases, but for the majority of individuals, there's no clear identifiable trigger. Some studies have suggested possible links to maternal factors like poorly controlled diabetes, viral illnesses during pregnancy, or exposure to certain medications, but these associations aren't definitive. In a normal heart, the aorta, which carries oxygen-rich blood to the body, is connected to the left ventricle, and the pulmonary artery, which carries oxygen-poor blood to the lungs, is connected to the right ventricle. In TGA, these connections are swapped. The aorta arises from the right ventricle, carrying oxygen-poor blood directly back to the body. Simultaneously, the pulmonary artery arises from the left ventricle, sending oxygen-rich blood back to the lungs. This creates two separate, closed circulatory loops, preventing oxygenated blood from reaching the body effectively. To survive, babies with TGA need a way for the two circuits to mix, usually through a patent foramen oval, a hole between the atria, or a patent ductus arteriosus, a vessel connecting the aorta and pulmonary artery. However, these connections often close shortly after birth, making timely intervention crucial. TGA is a relatively rare condition affecting approximately 1 in every 500 to 5,000 live births. It accounts for a significant percentage of all congenital heart defects that require intervention in infancy. While it can occur in any newborn, some studies suggest a slightly higher prevalence in males than females. Babies with TGA often present with noticeable symptoms shortly after birth. The most prominent sign is cyanosis, a bluish discoloration of the skin, lips, and nail beds, caused by the lack of oxygen in the blood. Other symptoms include shortness of breath, rapid breathing, poor feeding, and lethargy. As the condition progresses without treatment, infants may experience heart failure, leading to further complications. Diagnosis of TGA typically occurs soon after birth based on the signs and symptoms. A physical examination will often reveal a heart murmur. The primary diagnostic tool is an echocardiogram, an ultrasound of the heart, which allows doctors to visualize the heart structure and blood flow patterns. Additional tests like an electrocardiogram (ECG) to assess the heart's electrical activity and a chest X-ray to examine the heart and lungs can also be helpful. In some cases, cardiac catheterization may be necessary to gather more detailed information about the heart's anatomy and function, while the core issue in TGA remains the same, the transposition of the great arteries. The presence of other heart defects can influence the specific clinical presentation and treatment approach. For example, some infants with TGA may also have a ventricular septal defect, a VSD, a hole between the ventricles, which can allow for some mixing of oxygenated and deoxygenated blood. The presence or absence of a VSD, pulmonary stenosis, narrowing of the pulmonary valve, or other associated anomalies helps classify the specific type of TGA and guides the treatment plan. Treatment for TGA is essential and typically involves surgery within the first few weeks of life. Before surgery, medications like prostaglandin E1 are used to keep the ductus arteriosus open, allowing for mixing of blood and temporarily improving oxygen levels. The definitive treatment is an arterial switch operation. During this procedure, the aorta and pulmonary artery are surgically moved to their correct positions, with the aorta connected to the left ventricle and the pulmonary artery connected to the right ventricle. The coronary arteries are also reimplanted onto the new aorta. Following surgery, ongoing monitoring and care are necessary to ensure proper heart function and address any potential complications. Currently, there is no known way to directly prevent transposition of the great arteries. Because the exact cause is usually unknown, preventative measures are hard to implement. However, women planning to become pregnant or who are pregnant can focus on optimizing their overall health. This includes managing pre-existing conditions like diabetes, avoiding smoking and alcohol consumption, and discussing any medications with their doctor to ensure they are safe during pregnancy. Genetic counseling may be recommended for families with a history of congenital heart defects. Though TGA rarely runs in families, the prognosis for infants with TGA has improved dramatically with advancements in surgical techniques. The arterial switch operation offers excellent long-term outcomes for most patients. With timely diagnosis and treatment, the majority of children with TGA can lead normal, active lives. However, lifelong follow-up with a cardiologist is essential to monitor for potential complications such as arrhythmias, valve problems, or narrowing of the pulmonary arteries. Recent research focuses on refining surgical techniques, improving long-term outcomes, and understanding the genetic factors that may contribute to the development of TGA. Ongoing studies also explore strategies to minimize potential complications and optimize the quality of life for individuals living with this condition.